The new medications on the block for migraine treatment are the CGRP, calcitonin gene-related receptor antibody. They're humanized antibodies, the receptor blockers. Okay, they will block the receptor to prevent the CGRP, which is a pain-inducing chemical, from attaching to it and causing sensitization or pain. One of the issues, the good part, is this is probably the newest paradigm shift in the treatment of headache since the triptans in the late 80s, early 90s, and the first time sumatriptan was the first. So this is the newest and latest paradigm shift in migraine. If you do a jugular stick, this is how we knew this, in patients who are having a migraine or a cluster headache, there'll be enormous amounts of CGRP, calcitonin gene-related peptide. And basically what you're doing is finding a way to prevent that. You can't stop it from being produced. You can stop it from antagonizing or even sustaining or starting the headache. So there's right now 4 humanized antibodies. There's about 7 medications. There are a couple of small molecules that are doing the same thing. And basically this is all to deal with both episodic migraine, which are patients who have fewer than 15 headache days a month, secondary purely to vascular headache or migraine. And also studies have been done on the one that has been approved so far with chronic migraine. And so there's a lot of stuff that has not been unloaded. In other words, I believe one second NDA has been filed already. And so more drugs will be coming sooner rather than later in this class. 2 points more about the drug itself. Some patients in their episodic migraine study that has been published for the approved drug, you need to be on the drug because most of their data shows 4, 5, and 6 months after the drug starts. So typically you would assume, and from talking to people at the company, that you would need to be on the medication at least 3 months, and that may or may not be true, to be seen in the future. The other thing is they tried it on cluster headache and it worked for episodic cluster, but not so much for chronic cluster, which is a very difficult problem whatsoever. To try to deal with it, it's very difficult. I should point out that some of the CGRP receptor antagonists are being looked at for migraine abortiveness, the ability to stop a migraine. And how that's going to work, I don't know, because right now you can eat, the first approved migraine is a 28-day, every 28 days patients will self-inject this humanized antibody. And they have one molecule that will be every 3 months, every 90 days. Okay, the small molecules will be oral. Okay, the problem being you can't intake a humanized antibody because the acid in the stomach and the first pass, I mean, basically it'll destroy the drug. So you've got to give it in a way that it works like this. And yeah, the odds of a humanized antibody of getting into the brain any more than we know how onabotulinum toxin A gets into the brain. There's some thoughts, but nobody's ever proven anything. Nobody knows. The question of migraine diagnostics, if you will, it all comes down first to the history. And you need to be able to make your diagnosis from history because your neurological exam for your typical migrainer is going to be negative. One of the things that occurs is that right now there's about 39 million migraineurs, of which 18% of women in this country have migraine, 6% of men. There's a number of issues that it can be hereditary, it can skip 1 or even 2 generations. So you want to be careful if you say, well, there's no family history, you can't have migraine. One of the problems is many people, including physicians, unfortunately, will see a patient who has, quote, severe headache, and to them, severe headache means migraine. And I've had many patients come in, they've been given 4 of the 4 FDA-approved migraine preventative or prophylactic medications. The CGRP receptor antagonist is the 5th, okay? And they've had 6 out of 7 triptans, and they come in and say, I've got migraine, nothing helps. I've had every migraine drug in the book, and nothing helped me. And I said, yeah, probably the reason is you don't have migraine. The key is understanding that the definition or the diagnosis of migraine is not just severe headache. People can have severe tension type headache, which is muscle contraction headache. Muscle contraction headache or tension type headache can be secondary to also medication overuse headache, which can be analgesic overuse and or, for migraine, triptan overuse or vasoconstrictor overuse, including triptans and ergots, Migranol, which is DHE45. So you've got to clean that up before you can use a preventative or prophylactic medication.